Welcome to the Architecture of Healing, the podcast where healthcare strategy, design, and operations come together to shape environments that support care delivery and healing. I'm your host, Chase Miller. In healthcare, capital decisions are often made under pressure, and too often they treat symptoms instead of root causes. Today's guest, Bill Hercules, has spent decades helping health systems rethink how and why they invest in the built environment. As a rare triple fellow in the American Institute of Architects, American College of Healthcare Architects, and American College of Healthcare Executives, Bill brings a systems-level perspective that bridges design, finance, and healthcare strategy. In this conversation, we explore capital strategy in healthcare design, why expanding buildings doesn't always involve operational problems, and how executives evaluate value, ethical implications of evidence-based design, and what it really means to invest in outcomes rather than quick fixes. If you care about aligning design, dollars, and decisions, this episode will change how you think about every project. All right. Welcome to the show, Bill. It is great to have you with us today.
Oh, it's great to be here, Chase.
Awesome. I'm going to go back in time here about, I guess it was 3 or 4 years ago. I got the privilege of participating in one of your workshops, healthcare finance, and I was just enamored by the content and just the presentation and the practicality of how it applied to everything that I was doing on a regular basis. And since then, I've had the opportunity to hear you speak a few times, and I just knew that I had to get you on the show. So I'm really stoked to be chatting with you here today.
Oh, great. Thank you.
So you have a rare distinction of being a fellow in the College of Healthcare Architects, Healthcare Executives, and with AIA. What does that mean to you? How did you get from architect to such a well-rounded fellow?
I could tell you it takes a lot of work to produce those Fs. Each one of them is very different. And in chronological sequence, I got my ACHA fellowship first because I've been a healthcare architect most of my career. It's followed by my AIA fellowship and then my fellowship in the ACHE. I'd been active in all of those organizations as a member, absorbing all of the materials, et cetera. But the two architectural fellowships, the ACHA and the AIA, are really achievement-based. You know, what have you done that's created ripples across the healthcare design industry in case of the ACHA, or in the case of AIA, which most of whom don't really understand healthcare design, across the broader direction of architecture. And then the ACHE fellowship was an exam, which I'd been practicing at the time for more than 30 years in the healthcare space. I thought I knew all this stuff. Well, reality is I didn't. And I had to dig in with a number of my ACHE colleagues to sort through what does it really mean for healthcare accounting or healthcare law or a variety of other domains that I was aware of, but awareness doesn't necessarily translate to expertise or even practical knowledge. So fortunately, the American College of Healthcare Executives, which is a fairly large organization, 45,000 members, has a really good educational program to get you across the line. And the bigger idea is that it's a group of lifelong learners, and it is about absorbing this. So as a longtime practicing healthcare architect, I thought, if I really want to have an expert discussion with an executive within a health system, for example, I need to understand that person's points of pain. What's really driving them? What are the incentives around what they're doing? And it's not just in a departmental domain, but it's how does that relate to the overall hospital operations or even a collection of hospitals or ambulatory centers within a system. So that's the reason why I chose to pursue ACHE membership and then eventually fellowship. But the fellowship track really does separate those that sort of pretend and those that sort of demonstrate it, because it's a fairly rigorous exam.
With taking that exam and learning that language, so to speak, how have you seen that kind of impact the work that you've done and have done since then?
Well, you mentioned my presentation at HCD related to healthcare design and finance. If I could back up a second, when we're in architecture school and we're talking about design, we're talking about design from a theoretical standpoint, and we're removing a lot of the practical constraints just to allow us to think. I don't want to bang on the pedagogies of architecture schools directly related to that, but we never really come back to the practical realities of what do things really cost? What is the value of what we're creating? How do we translate that value in terms of dollars and cents or investment or other things like that? So when we get into our practices and we're licensed, we're not about finance or really understanding those inner workings. We might hire an accountant because many architects really sort of have an aversion to finance, and it's a natural thing. And if you talk with any of the architectural management consulting groups, they'll tell you that engineers make much better managers of practices than architects do, largely because of those traits. And again, this is not bashing anybody. It's just the way that personalities are shaped. So moving forward, recognizing the significant gap between what architects should know and what they really don't know, a few colleagues of mine and I put together this series, and ultimately it was a 7-part series for the Center for Health Design, which included a number of different subject matter experts. But it was talking about the impact of healthcare finance on design and how do you translate that value. Well, first of all, you need to understand the language. Most people don't understand the 6 functions of a dollar, for example. They might be able to calculate simple compound interest, but in terms of what does it really mean to do a net present value assessment? Well, I don't know. Isn't that a function in Excel? Yeah, maybe. Okay, but what does it really mean? I don't know. So those kinds of things at a very basic level is where we started, and then we matriculated into a little more complex things in terms of how CFOs view the world, which is very different than how architects view the world.
Yeah, and I would imagine that translates into decision making. And as a designer myself and an architect myself, thinking about how we make decisions regularly on a project. I mean, you're making thousands of micro decisions every time you're opening up your documents, and having that understanding of what's the business case behind how this project is going to be seen as successful or not really does impact what you're doing and how you're thinking about those micro decisions all along the way to get from that early design phase to a completed project.
It is a question of aligning mindsets related to what an aspirational healthcare project might mean to a community. The board's narrative, the 5 talking points that every board member is walking around the community talking about related to this, and how it operates on the inside, the real balance between revenue and costs, and the relatively thin margin that most health systems seem to eke out at the end of the year, and especially nonprofit ones that are driven primarily by mission, they still have to generate a profit. Many years ago, I think it was in the mid-90s, there was a fairly pejorative article in the Wall Street Journal that was bashing the Daughters of Charity. They were calling them the Daughters of Currency. And it was not good. Eventually, the Daughters of Charity became Ascension. There were several mergers that kind of merged into that. But the chair of the board of Ascension, who was a nun, said, look, if we can't make some money on any kind of investment, then we are not going to be able to sustain ourselves. We can't make it on our margin alone. We need additional sources of income to supplement our mission. Yeah. So no margin, no mission is how the phrase ultimately got reduced to. But the point is absolutely true. And architects really don't know how to deal with that directly. They'll get hired, and it's usually by a director of facilities that's running things. And it's okay, let's get into the work right away. Yeah, we need so many of this type of patient room, exam rooms. And, we could talk about sustainability. We could talk about all kinds of other things, but that's the archispeak of getting a project done. But 5 years after the opening day, after the pictures have faded and the architects have been on to multiple other projects, what's the real value that building is contributing to the community and to care? Health systems are not in the building business. They're in the care business.
Yeah.
And as such, the building is a tool to facilitate that care, but it's not the end into itself. And sometimes architects are they can't quite get to that space.
Yeah, there's a lot of pride in that final design as an architect and a designer. It's like, this is the end thing. And for a healthcare executive and a healthcare system, it is a means to the end thing, right? So it's kind of shifting that.
It's also a reflection of what the health system is, what it is aspirationally, what it is as a purveyor of services that are literally life and death services, the confidence associated with that level of risk and sobriety. Beautiful hospital, for example, does contribute to the fabric of the community in that it projects the confidence of the institution.
Absolutely.
And I would argue all day long that it does need to be a beautiful piece of architecture. And if you work for municipalities, county-owned hospitals, that sort of thing, where everybody's scrutinizing all the money all the time, sometimes it's dialed down slightly, but it does still need to project the confidence that they're actually going to heal me here. And when I come here, I've got hope, not just in the architecture, but the architecture is a symbol of the operational excellence that the health system is pursuing.
Yeah. And even taking that a step further with the changing in landscape of certificate of need across the country here recently in the last few years in Florida, where you are, thinking about that architecture itself is going to kind of indicate not only the quality of care, but it's also going to drive where people go. And if there's this higher level of competition between systems, then you're going to see this really evolving and ever-changing landscape of how people select where they receive care.
Yes and no. There are two sides to that coin. And if you look at states where the CON really never happened, or it was abolished a long time ago, states like Texas, for example, there are clear winners and losers. We're going to let the market decide. Okay, that's not without a bloodbath. A group of physicians decides, yes, we're just going to break away from the system. We're going to mortgage our houses. We're going to pull some money together and go out and get a loan, and we're going to build a 150-bed hospital. Okay, go ahead. Good luck. And then, well, how are we going to operate? I don't know. We can find somebody to do that for us. What about your manager that does your clinics? You think you could do a hospital? Yeah, sure. And then 5 years later, 5 years after it's all done and they've been operating, it goes bankrupt. The CON laws, in part, are designed to regulate that kind of thing, because when a hospital goes bankrupt, it's not a good thing. But in Florida, we've had this very strange phenomenon, because in 2019, when everything just hit the fan, and the Florida Hospital Association was not expecting that. That's the lobbying group in Tallahassee. They were not expecting this. There were several people within the Florida legislature, which were deregulate everything now kind of folks. That's how it all came to be. So I remember I was moderating a panel for a regional AIA conference. And earlier that week of that conference is when the announcement came that CON's going away. So we happen to have the vice president for project activation of a major health system on the panel at the time, for-profit system. And he's got a kind of funny sense of humor. And he said, and we couldn't not talk about this topic. I mean, it was just clear and present. We had prepared all the other stuff that we were going to talk about. We had to pivot and talk about this. And he said, I'm here to announce that by the end of this year, we're going to have 14 new hospitals under. And everybody just sort of, oh, he's joking, right? We hope. It was just, okay, I guess this is real. And the reality is, they didn't. but it did open the floodgates, and it really allows a lot of the systems to do whatever they feel like they need to do. And it's interesting looking at how the systems approach things and how the data that they're looking at has evolved and how they're using that data. It used to be that when you did a master plan or a strategic plan, the business strategy looked maybe 5 to 7 years ahead, and which is really enough time to get a project completed, but not much else. A master plan, let's look 20 years ahead. Well, you're really not. You're only
Yeah.
creating opportunities that might evolve in a 20-year period. But the data associated with that was looked at over the course of a few years. Now it's every hour they're looking at this data and using it to make business intelligence decisions. This crosstown rival just bought this land. Okay, well, that means that they're likely going to be da 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 da. But we suspected that because of the growth of population here, and especially in high growth states like Florida. And Florida has the highest population over 65, which is the highest consumers of healthcare services. It's sort of the Wild West when you pull all these things together. It's a very volatile mix.
Yeah.
So if you're a health system executive and you're trying to, working within a system, not just a hospital, within a system, and you're trying to outgame all of your other competitors, it becomes really kind of a four-dimensional chess game in a way.
It does. And it takes the focus a little bit off of the patient in some ways. Like your focus is all on providing this high level of care. And now this gamified environment of, I need to do this over here and this over here, so that guy doesn't do this thing over here. And you're a little bit distracted.
I would suggest it's not an either or, it's a both and.
Okay.
The business just got more complicated, but knowing a number of these executives, they are very focused on patient care and doing the right thing by patients. And especially in the nonprofit space where it's about a mission, and the mission is a collection of platitudes, and they actually measure their performance against those.
Yeah.
They're really focused. It's just the means by which they can accomplish that just gets a lot more complex.
So, with your involvement with ACHE, have you seen where the executives you've been interfacing with don't have a good understanding of the design side? So you've identified this hole where designers don't really understand the business side of healthcare. Has that been made apparent in the converse?
Well, that's an interesting question. I think by the time somebody reaches an executive position, either in a hospital or in a system, they've generally been involved in some sort of architectural projects. Sometimes it's more than, hey, yeah, I built my own house. It's we've designed an expansion to our ED, for example, or we've outfitted some shelf floors in our bed tower. Typically, they've got some understanding of some basic parts of the process, enough to ask some questions. And the better executives will ask some really deep questions of their designers. But most of the time, they're not directly involved. Architects are working with the facilities project manager, and sometimes that's even somebody that's outsourced. So there's some degrees of separation between what's really driving things and how the design is evolving. So in some ways, there are a few of us that step into that gap. And when I started my sole practice almost 13 years ago, that was the gap that I was trying to bridge. Over that time, even others have done very similar kinds of things, so it's not all that unique anymore. And the data sets have become a lot more ubiquitous. And now AI tools are very useful to sort through all those data sets. And it's basically the same data that the health systems are using. It used to be that it was very unstructured and, okay, give us your, the laundry list of data requests, and it would come back in a variety of different ways. Now it's fairly structured and you can make intelligent decisions about it. But in terms of the research associated with how certain environments help people heal faster or reduce risks or other things like that, I think, frankly, architects have an opportunity to step into that gap and really assert their professional authority. And many don't. So if you're a healthcare executive and you're managing this system, you're not the surgeon, you're not the hospitalist or a nurse, but you're managing the system of things. This is about managing things so that they work all of the time. And that's about reducing risk. It's about improving margins so that you can do other kinds of things like capital improvement projects or other things like that. It's a different mindset. And frankly, that's the reason why they want to hire somebody that's expert in this field of architecture.
Yeah.
But I think that, and many people have opined about this, architects have really stepped away from the grabbing the bull by the horns and pursuing a higher order of design excellence, not just aesthetically, but functionally, physiologically, neurologically, that sort of thing. They haven't dove into the neuroscience, for example, of how certain spaces or even colors really affect certain outcomes or conditions during recovery.
Yeah, there's so many different layers to it. As you're designing a space, you're following the latest and greatest codes and applicable authorities having jurisdiction and all of those good things with FGI and life safety. And then there's this next layer of best practices, research. What you should do? This is what you have to do. What really should you do to take this environment to the next level to really invest and care and treat those patients in the right way? And
Well,
you've
it begs some interesting questions. I've talked about this in many of my presentations. If you look at what the codes say about the value of natural views, which is well documented in the scientific literature, in the Center for Health Design's Knowledge Repository, or even the National Institutes of Health's PubMed, and you look at where the International Code Council is on that, or National Fire Protection Association, or even the FGI, they sort of glance at it. But if, all of those address windows, okay, if NFPA is about saving lives, allowing the fire department in and out, that sort of thing. Okay. A window is a device to facilitate that. But they don't discuss in any of the NFPA documents what the value is to a patient in a hospital therapeutically. Okay, well, maybe that's a little outside of their lane. Okay, let's give them that. And this is not to suggest that NFPA's code language is inappropriate. It's about saving lives. Okay, absolutely.
Yeah.
We need that. Okay, well, let's look at International Code Council. They're silent. Let's look at FGI. Some references to it, but it's sort of suggestive and that sort of thing, as opposed to being prescriptive. So I would argue that most code language is retrospective, looking back at, okay, this is what we generally think we need to do here because of certain conditions, because we found out certain things or bad events happened and we need to safeguard against that. But it's mostly retrospective.
Yeah.
As opposed to being prospective, looking ahead. Now, to be prospective about this introduces another ethical question, an ethical dilemma of, okay, this is what the research says, Mr. Hospital Administrator, related to views of nature and what the therapeutic implications are. These are the limitations of that research. This is how we want to apply it here. And the implications are that there will be wider windows, that sort of thing. The building envelope is going to be slightly more expensive as a result of this. The operational costs associated with glare control and heat gain and other things are going to affect things long term. We're not having those conversations, but allowing that executive to make some intelligent decisions about, okay, therapeutic benefit of this can get us so far.
Yeah.
And again, who is going to bring that? A program manager's not, a constructor's not, an architect should.
Yeah, I completely agree. Along those lines, I recently did a project in an ICU, and I brought this research about utilizing overhead booms in lieu of head walls to allow this kind of flexibility. And ultimately, the owner decided not to proceed with that given kind of the stark cost differences and the level of care they were trying to provide. But I think, to your point, I think the responsibility in many ways is on the design team to bring that type of information. I guess my question, or I guess what I struggle with that idea is there is infinite amount of topics out there, an infinite amount of research. The body of knowledge is so deep and in many cases a lot wider than it is deep. How do we really know what's out there to be bringing forward?
I think that the Center for Health Design does a very good job of cataloging what is there specifically related to this. And if you talk to Ellen Taylor, who's the vice president for knowledge at the center, she would say that even that body of knowledge, which has, I haven't checked in a few months, maybe 6,500 entries into it, some of almost all of which have some level of peer review, even if it's a project and a case study, it was reviewed by a jury, for example, during the awards. Or if it's a scientifically peer reviewed case study, it went through that level of rigor. So there is some rigor associated with this. But if you compare that, let's say 6,000 ish articles to the 38 million articles in PubMed,
Yeah.
I mean, it's ridiculous. So more than 6,000 to 1. Whatever we think is important, it gets lost in the panoply of that. So and granted, the things in PubMed may relate to how certain cells metabolize certain types of proteins in a certain kind of condition. Okay, so it's very obscure, doesn't really have a lot of application in design, but that's the breadth of things. So if you consider how physicians do this, they go through medical school, they go through practice, they continue to read the knowledge associated with our medical knowledge and its application compounds almost daily now.
Yeah.
So a few years ago, the stat was it'll take a physician 25 hours a day to keep up with things.
Connecting this topic back to the healthcare finance lane, how do you take this research based concept or element? I mean, sticking with your example of Windows, and articulate that into a tangible business case to say, yes, it's important to invest these dollars today because it's going to pay for itself over X many of years. How is that conversation had in terms of prioritizing that initial decision to proceed with some of these things, even when sometimes the math doesn't even make sense, but it is important?
The essence of that means that the architect really has to do his or her homework. And in a particular hospital, in a particular climate zone, and a variety of factors that weigh into things, what does this mean in terms of long-term operational costs? That the facility director is going to say, my utility bills are going to go up. Now I'm going to get banged on by the COO all the time that this hospital is just more expensive. How did I let this happen? That sort of thing. And I'm going to be constantly fighting that battle. The design team has to do the homework around the implications of these things. Well, what about the therapeutic benefit? The seminal study that happened in the mid 1980s that everybody refers to, but very few people have actually read. And it related to what a view to a window is the name of the study. It looked at nature versus looking at a brick wall on the other side. Well, the results were the people that looked at nature, they got out quicker. They used less analgesics. I mean, there were some benefit associated with this. Okay, well, what's the cost of analgesics? Well, architects don't know. What's the cost of an average length of stay? Well, there's some benefit associated with that for a patient, but there's also some benefit in keeping patients there longer from the hospital standpoint if they can get reimbursed for it. So, I mean, sometimes healthcare is full of all kinds of ridiculous, perverse incentives. Not to suggest that was the reason or anything, but when we're looking at the benefits, sometimes the benefits have other costs associated with it. Reduced earnings or reduced threatening.
Yeah.
So
Yeah.
having an intelligent discussion, you got to do your homework to come prepared to have the intelligent discussion. You can't just wing it off the cuff. You're going to lose every time. And then you're going to complain, well, they just don't get it. It's because you didn't do your homework.
And I really think that drives home the need and the importance of that functional program at the beginning of a project, of highlighting what's the space really going to do. In the case, in the example I shared about the ICU, like we didn't have a really fully vetted functional program because the pro forma was evolving as we were designing it, and the types of patients were changing as we were designing it. And so we didn't know exactly what types of patients and level of care they were needing to provide. And so we were trying to connect the dots and say, well, you could do this is a great idea, or you could do this. And I think if you have that really vetted with the owner and the executive team early on in the project, that really allows you to do your homework on those specific items rather than homework on 10,000 items.
It can, but what your example highlights is the dynamic nature of how the building is ultimately going to be used.
Yeah.
And design, the perfect design happens in an instant and is applicable for that instant. Anything beyond that, who knows? So it's perfectly designed for that time, for that particular collection of events that are coming, but seldom really recognizes the range of potential of these kinds of events and what that might mean. Now, that's not to say that you can fine tune a patient room so far. Generally, most people will accept certain things in a broad conceptual kind of way, and it'll generally accommodate the needs of what's going on for a long time, for decades to come. But the way that care models evolve every few years, we got a new director, nursing director. People went to a conference, so those kinds of things continue to evolve more rapidly than the facility does.
And to that point of flexibility and the evolution of how care is delivered, when you are working with the systems you partner with, how often do you get in kind of the discussion of, we think we need X and it's going to be this new addition, millions of dollars. And in reality, it's a, hey, you just need to tweak the dials here in this existing space, and it can get you through the next X number of years. And it's more of a fine tuning of what you have rather than a wholesale change.
The classic example of something like that is our ED is way too crowded. We're boarding patients in the corridors, and we need to expand it. We need to add 50 new exam rooms in our ED. Oh, okay. So we're going to go out and get a bunch of architects and make them do dog and pony shows. We're going to select one and go. Oh, by the way, you're over budget late. Just keep going. Go, go, go. We need more exam rooms, more exam rooms. Okay. Why do you need more exam rooms? Well, because we got boarding and blah, 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 blah. Okay. Well, why? You start asking the questions. Every 3-year-old has an incessant collection of whys. But somehow when we mature, we take shortcuts around that and stop asking the questions of why. And typically, and this has happened multiple times, and almost every mid-level healthcare architect has experienced it at least once, if not multiple times. It's the inability to discharge patients out of the bed tower. Well, why is that? Well, because the physicians aren't rounding, or we can't get the rooms clean, or we can't, a variety of other operational issues that are creating this backlog into the ED. So then we're going to spend $50 million to expand this ED. And when we could have solved the problem for 2% of that, and then it's solved permanently. It is a weird quandary of asking the right questions, but it gets back to the issue around a functional program. What is this project really supposed to be doing? Ken Cates, who was the board chair for the FGI for many years, did a great podcast on the need for a functional program and what it really is and why people always resist it. And then once they do it, it's, oh, wow. Well, of course. Why wouldn't we do something like this?
I've worked with the Center for Health Design for years on advocacy for the functional program and with the Environmental Standards Council. And I'm going to be sure to link to that podcast here in the show notes so that people can find that because I do think that's hugely important. And what's interesting with the example you described with the emergency department, if you do in fact add more emergency or exam rooms, you only compound the problem and make it worse because you have that many more patients you can't get in and admitted, right?
Right, right. Well, it's an easy button, and sometimes it's the right thing to do politically.
Yeah.
There are a variety of things that are intangible, or we have a donor that's going to give us a bunch of money for this. Okay, there's no health system that will turn down donor money. So,
Yeah.
so okay, then that'll be the solution. Is it the right one? It doesn't matter. It's being paid for.
Yeah. Well, I absolutely love the advocacy work that you do around this and your involvement with AIA, ACHA, ACHE, and just how you continue to push this mission forward with how we leverage design research at the strategic level of healthcare development and capital allocations. I think it's hugely important and something that doesn't get talked about nearly enough in the space that we work and play in most of the time. As we round third here coming into the end, I do want to hit a couple of key questions as we wrap up and then our lightning round. But thinking about healthcare as a whole, from the finance and the strategy side all the way to patient care, what's something that you could change or redesign that you feel like just needs completely overhauled?
Well, I'm going to step out of the box with this one. So the easy answer might be we've got to tweak an exam room or something like that. I think that the health systems are designed in a reactionary kind of way. And most of the preventative health measures are not used by most of the population. Consequently, and we've created a significantly complex and very expensive apparatus to support that bad behavior. So if I could change anything, I would change the behaviors of people that continue to consume bad foods, that won't exercise, that won't take care of themselves because somebody else will do that. Across the US over the last few years, there have been a number of referenda within various states related to normalizing marijuana consumption, legalizing it. Now, for a variety of reasons, a number of people just want to do it. Hey, I'm exhibiting my freedom. I could do this. It's my body, my choice, whatever. Okay. Well, the realities are, if we look at this, with the exception of some very few neurological implications related to Parkinson's and other kinds of things, where certain parts of the chemicals can be used and are actually effective. Just smoking a joint, for example, you ingest 4 times the amount of tar that you do in smoking a cigarette.
Wow.
Okay. So that means that your lungs are going to bake 4 times as fast. They're going to be crusty 4 times as fast. So you're going to accelerate your COPD or your other bronchial issues. And who's going to pay for that downstream? It's your exercising your liberty at the expense of others, the arbitrage of the entire system.
Yeah.
That's been healthy. And if we look at the World Health Organization's definition of health now versus it used to be the absence of disease. So I don't know how you define something as the absence of something else, but that's what it was. But now it's this sort of perfect nirvana, holy, everything, perfect state of well-being. That's how I'm grossly paraphrasing what the World Health Organization does, and I'm sure you can put a link into that also. But we're not marching towards that, and we're not accepting personal responsibility for our health. Change anything, I would change that.
Personal responsibility for your health, like wholesale.
I think that's it. But it's so easy to not be healthy. It's so easy to grab a Coca-Cola for breakfast in the morning.
Yeah.
There's nothing in the water in the Coca-Cola isn't even healthy because it's been contaminated by all kinds of other chemicals.
That's a very interesting way. And even when I ask this question, I go way up here, 50,000 foot view. You've gone to outer space on me.
Well, we've created this apparatus of convenience that facilitates bad behavior.
Yeah.
And arguably, it's not sustainable financially. We've managed to do so because we're a fairly affluent nation, but we still have the highest rates of diabetes and obesity. 70% of American adults are obese,
And what
overweight or obese.
and, and two, that gets to the cultural aspect of health. And you can see that in healthcare expenditures and average quality of life between different countries. And seeing how America is one of the largest consumers of healthcare and spends the most out of any other country on healthcare. Culturally, what does that say? And how do you correlate that with other countries that may have different cultures and different behaviors around food and activity and the conversation around blue zones and all of that. So that's so interesting to think
Well, you
about
bring
in
up
that
Blue
way.
Zones. One of the scientific directors of Blue Zones is a former client of mine.
Okay.
And I asked him to opine on some of the work that I was doing within the AIA as I was pushing the architecture and well-being initiative forward, which ultimately in 2024 was adopted with an overwhelming supermajority at the AIA's annual meeting. But the point is that there's all kinds of data that really does support this.
Yeah.
And it's a question of, are we even talking about this as an architectural profession? Generally, no. And we could talk about LEED and environmental quality all day long, but even the superstar firms are generally not, although there are some that absolutely do, are generally not measuring the qualities of their commitment to the 2030 challenge. I
Yeah.
mean, those kinds of, it sounds like a great idea. Yeah, we're mostly in. We're not going to say we're all, well, we'll say we're all in, but we're not really, that sort of thing. And I'm not throwing stones. It's part of human behavior.
Yeah.
I didn't drink a Coke for breakfast, but I didn't exactly have a healthy breakfast. It was a Raisin Bran. Okay. If I really dive into the ingredients of Raisin, there's a lot of preservatives in there. There's a lot of other things that are not healthy for me. In fact, my wife and I have 8 grandkids, and every once in a while they'll come over and she'll get chocolate milk. And then they leave, and then there's half a container of chocolate milk, and I'm like, okay, just feel like a little kid, so I'll get some chocolate milk. So I decided I was going to look at the ingredients of chocolate milk.
Oh, bad idea.
Well, it's a dangerous thing. Don't do it. But I'll tell you what I saw. Low-fat milk solids, high fructose corn syrup, about 5 $20 chemical names. Then at the bottom, it says caution, may contain milk. So, I don't want to say the food industry is arrayed against us because that sounds too conspiratorial, but we've got to really pay attention to what we're doing. And getting back to what would I change, it is about being personally responsible for your health. And it requires a lot of personal diligence around it.
Yeah. That's huge. So let's jump right into our lightning round. So we got a few quick questions to close us out here. What is one of your favorite healing spaces?
The beach.
Excellent.
And I say that because it's not just about how does the space contribute to healing and it's finely tuned, that sort of thing. I think God did a much better job of tuning that than what we can. So
Yeah.
I'm going to say the beach.
Yeah, that's a phenomenal answer. Now, I would much more appreciate the beach without a little of the sand, but personal preference.
It's part of the deal. You could walk barefoot.
My kids love it. I tell you what, my kids absolutely love the sand. So what inspires you outside of work?
I do a number of different things. I'm involved in a variety of special projects. I've got a couple other businesses that I'm starting or have perpetuated. So I think it's the activity associated with all of those things. I used to think that an entrepreneur, a real entrepreneur, is somebody that's been rejected at least 5 times by some sort of venture capitalist. So, having gone through some of that kind of rejection, you sort of learn from those and just pick them up and just do them.
Yeah.
But I'm involved in a kind of a regional arts group, performing arts, musical arts, graphic arts. It's almost a ministry in a way. I'm involved in a project that is like a 300-acre mixed use project for special needs families.
Okay.
Uh, for my kid's going to age out of the system, or what happens when I pass away? Who's going to take care of my special needs kid, and how do we deal with all of those kinds of broader social issues and engage them as very important people that do have purpose. And while they might have some limitations, other things they're just off the charts on in terms of their abilities. So it's just different than what most people are encountering. But it's a matter of developing those things. I've got another a research team that I've been involved with for 6 or so years. We've been doing this writing related to the ethical implications of not employing architectural research and what that really means. We just won our second grant, so we're north of $300,000 of grants that we've won as a kind of a ragtag weekend warrior team of really smart people, architects and physicians, bioethicists, that sort of thing. And I love playing with my grandkids.
Yeah, with all of that, I mean, I do have a follow-up question. Like, when do you sleep?
Oh, I sleep very well. It is a matter of saying no to some things so I can say yes to other things.
Yeah.
But the things that I'm saying yes to, I think have meaning that is well beyond who I am.
So true. So true. What is a book that has changed the way you think?
The Bible. I'm serious as a heart attack. What the message is about God's plan of redemption for all of mankind. We've been talking about the dysfunctions associated with healthcare and lack of personal responsibility and all those things. I firmly believe that it's a spiritual issue before it's a functional issue like
Yeah.
that. And
Yeah. It gets to the heart of it for sure. And finish this sentence. The future of healthcare is blank.
ever changing, ever evolving.
You can't pin it down. It's just constantly
It
fluid.
will constantly change and constantly evolve. It is so tied to finance. You remember when you were in architecture school and Louis Sullivan's riff, form follows function. Well, there was an urban planning professor at Columbia that wrote a book in the mid 90s called Form Follows Finance. And I thought it was a great riff on Louis Sullivan's. In fact, when you read the context of what Louis Sullivan wrote, he wrote it in Lippincott Journal in the late 1800s. And he was talking about natural things, and in nature, form ever follows function. But he was talking about how trees evolve and or mature and develop, and other kinds of natural systems. And if you think that form follows function in that kind of a way, when you have unlimited resources, when God says, okay, yeah, I'm just going to do this.
Yeah.
Okay, great. But all of us have financial limitations.
Yeah.
So
Yeah.
we don't have that luxury.
We can't go and make a beach anywhere we want, right?
We cannot. We cannot. So I think that because of that, and because of the economic pressures on the health system, not just within the United States, but even globally, what's going on in Canada is very difficult to watch. What's going on in the UK, extremely difficult to watch. And even personally, at the end of the year, everybody's sorting through their insurance and what that really means, and the gamesmanship associated with, okay, the government's going to make some money available, and okay, the first person that touches it grabs it. Okay, well, and then it's couched as a benefit to me. Okay, the reality is my illness is only an opportunity for others to make money. Okay, how perverse is this?
Yeah.
So it's going to be ever changing.
Yeah. I think that really summarizes healthcare. You know, just when you think you figured it out, it moves on you. And it just evolves and is so fluid with the change in legislation and the change in culture and the change in behaviors of people, to your point about changing healthcare and human behavior. And we're just never going to figure it out, but we just keep putting one foot in front of the other and working to achieve good for those that are receiving care and participating in the healthcare system. Bill, this has been a phenomenal conversation. I want to thank you again for joining us here. I truly appreciate your perspective, your advocacy, and all of the great work that you're doing across the country and even globally, I believe. So thank you again for joining us.
Great. Thanks, Chase. It was fun.
Thanks for joining us on the Architecture of Healing. I hope today's conversation brought you fresh insight and inspiration. If you found this episode valuable, make sure to subscribe, download, and give us a review. Want to learn more? Keep the conversation going and head on over to thearchitectureofhealing.com. We've got more great conversations on the way, but until then, keep shaping the future of care through thoughtful strategy, smart operations, and purposeful design.